Good morning, everyone. Thanks for joining us this morning for GIM Grand Rounds. I'm really excited to introduce our topic and speaker for today. We'll have Dr. Caroline Robb, who's here with us from the cardiothoracic imaging section at the university to talk to us about chest radiography for the non-radiologist. So I've known Dr. Robb actually since medical school. She did undergrad and medical school at WashU in St. Louis, then stayed there for her residency at the Mallinckrodt Institute of Radiology, and then did fellowship in cardiothoracic radiology. Dr. Robb is truly an expert in this topic, is very involved with her professional society, the Radiological Society of North America, having won multiple educational awards there. And when we were getting ready for this Grand Rounds this week, was flying all around the country for other conferences. So I think really we're in for a treat, and hopefully to get a primer, refresher, additional knowledge wherever you are in terms of your own chest radiology. If you have questions as we go, please type them in the chat. If you're watching via Zoom, I'll be watching that, and I can ask those for Dr. Robb. If you're here in person, in the audience, raise your hand and I'll walk around with a microphone.
All right, thank you so much for that introduction. We're just going to dive right in so we can cover as much as we can. And I have nothing to disclose. So the way we're going to approach the next 45 minutes or so is we're going to ask and answer 3 questions regarding chest x-rays. First being, how do you even look at a chest x-ray? You have this black and white image in front of you. What do you do with it? Second question being, when do you order a chest x-ray? Third one being, okay, what do you see on the chest x-ray? So to answer these 3 questions, first off, we're going to review a standardized approach as to how to look and read at a chest x-ray. We're going to assess what the common indications and limitations of chest radiography is in the outpatient setting specifically. And then we're going to discuss some common outpatient cardiac and pulmonary findings that we see on chest x-ray. So we'll start off with the first one. How do you look at a chest x-ray? Well, first I just want to start off with some basics, some terminology. If you see a white area on an x-ray, you're going to call it radio-opaque or an opacity. You are not going to call it an infiltrate. That is old, antiquated terminology that we do not use anymore. If you see a dark area on the chest x-ray, you can call it radiolucent or a lucency. Now, the technique of x-rays, there's not a lot of variation across it, but there are some small differences that do impact how we interpret these images. So most often when we see chest x-rays, they've been ordered as a single view. That's a frontal view of the chest, and it can be performed as an AP or anteroposterior or a PA, which is postero-anterior. And in case you're not aware or need a quick refresher on this, that terminology or that technique depends on how the image is acquired, which is showed in this wonderful little diagram I've made for you on the bottom right of your slide. So the black bars are the detectors. So that's kind of where the film would be, so to speak. This nice little yellow circle with a heart in it is a cross-sectional view through the chest with the heart positioned at the anterior part of your body. And then the blue circle there is an X-ray source. That is where our electron beam comes out, and that is important. See here. So our electron beam comes out as denoted by this blue dashed line, and then it hits the heart. Now, depending on where that heart is located in reference to that detector, there's going to be a certain amount of scatter. So when that X-ray beam is going from posterior to anterior, you're going to get less scatter. That's on the left side of that image, and you're going to get a smaller cardiomediastinal silhouette. When you're doing an AP or anteroposterior view, and that's denoted on the right side of this figure, you're going to get more scatter because the heart itself is further away from the detector or the film. So then you're going to get a larger cardiomediastinal silhouette. This is important to remember when we start talking about how to assess cardiac size. So going back to the technique, in addition to this frontal view, you can also get a lateral view. And then in some cases, you can also order a lateral decubitus view. We're not going to go into much in detail about that here, but there are some scenarios where that lateral decubitus view can be helpful. All right. Oh, yes. And the white bars are now the size of your heart. Okay, so first off, we're going to talk about a search pattern. So here is a normal two-view chest x-ray. We have a frontal view on the left and a lateral view on the right. So every radiologist has a slightly different search pattern. What I tell my residents is I don't care what you look at as long as you are looking at the same thing in the same order each time. That is how you avoid missing anything. So I'm going to share with you what my search pattern is. So first, I look at the lungs. Then I look at the pleural surfaces. In my mind, I separate the two because that is going to lead you down two different differential paths. They have different potential differential diagnoses. Finally, I look at the cardiomediastinal silhouette. And then, so we don't forget anything, got to check our blind spots. So if you'll notice here, our blind spots are where there's more tissue, there's more opacity on the x-ray film. This is where things like to hide, where it's easy to miss. As a radiologist, I'm expected to find these locations. As an internal medicine specialist or in the outpatient setting, if you guys miss this, that's okay, but just be aware that things like to hide here. In older literature, you will sometimes see or hear this referred to as the eye of Clare, eye as in the letter I, not the eyeball. And you'll notice that's because this makes the shape of an eye, basically. All right, so just a little note on why we need to be aware of blind spots. So on this frontal chest x-ray, there is a pertinent finding. There's a right apical mass, commonly referred to as a Pancoast tumor. Another clue about blind spots, and this is kind of a little plug for inverting our images. So here there is a pertinent finding on this image. And in this case, I personally find that the inverted image helps. You'll see here that there's this rounded mass that's hiding behind the heart right there for you. So again, blind spots. Now, the next thing we're going to talk about, because this is going to kind of come up several times, is this concept of silhouetting. Now, what this concept describes is how two objects of the same tissue interact on a 2D image versus how those same objects interact if there's an intervening other soft tissue media. So, for example, on this top row here, we have our two opacities, our white blobs or circles. But between the two, we have this gray space, which is typically what air or gas will look like on a chest x-ray. The bottom one is two white blobs or opacities, but they're directly touching each other. So if you were looking at this directly on, kind of en face, just as what these eyes are symboling here, what you're going to see on that top is you're going to see that thin gray curvilinear lucency, because it's darker, separating those two white objects. The bottom, you're going to see those two white objects kind of merge together. You can't distinguish them from each other. So this concept is going to be used to help us localize processes in the chest when we're looking at a chest radiograph, and through that localization, help us kind of parse out what our differential diagnosis is going to be. All right, so you're thinking, okay, cool, animation. You spent like 5 minutes on that. So what? Why does this matter? Well, as I just said, this can help us decide, is this a parenchymal process or a pleural process? If it's in the parenchyma, is it actually mediastinal? Where is it at in the mediastinum? So using this concept can help us answer all of these questions. So this is an example here. Two different patients, two frontal chest radiographs. On the left here, we've got this mass kind of in the left lower lung. And on the right image, we see that we also have this rounded opacity that's kind of hovering over the right hemidiaphragm. What do we do with these? What kind of differential do we provide for this? So these are our findings, as I just kind of pointed out for you, and I'm going to zoom in on them for you. So here on the left image, that yellow arrow is denoting that thin linear lucency. On the right image, the arrow is showing where you would expect to see that interface, but you don't see that linear lucency anymore. You don't see that dark area. So this tells us that the left image, where you see the lucency, that dark line, that's actually in the lung. It's not part of the heart. It's not touching the heart. It's not touching the mediastinal structures. It is a pulmonary parenchymal process. On the right image, this is actually a pericardial cyst. So it's arising from the pericardium. It is not a parenchymal process. You do not see that thin dark line. So kind of keep this in the back of your mind if you can, but we'll refresh on it when it becomes pertinent later on. All right, so that's our first question answered now. Second question, when do you order a chest x-ray? Oh, that is the wrong direction. Okay, so when to order a chest x-ray? You are all familiar with the common indications. If you're looking for any sort of pulmonary disease, pleural disease, a mediastinal process, even cardiac processes for preoperative workup, pericardial effusion, devices, heart failure, whatnot. Pertinent thing being, I did not mention rib fractures. You do not order a chest x-ray to look at rib fractures, and I'll show you a few examples of why, but it's actually very important. So specifically, if you are suspecting a broken bone anywhere in the chest, you're going to order a dedicated x-ray of that body part. You can get rib fracture series x-rays, you can do clavicle x-ray series. You do not need, nor should you, order a chest x-ray to evaluate these structures. First off, the way the x-rays are performed, technically speaking, it's different. If we want to look at the chest, we're trying to look at a structure that's mostly filled with air. As you can imagine, the kind of electron beam that we're going to need to expose that chest to is going to be different than looking at mineralized osseous structures. So the technique is different. Secondly, the standard chest views that we get just are not good for looking at rib fractures. Yes, we can catch some rib fractures, especially if they're moderately or markedly displaced, but the vast majority of rib fractures, especially that you're seeing in the outpatient setting, they don't fall into that category. So we want you guys ordering the rib fracture, the rib x-ray series. Yes.
So I have a follow-up question on that. And I think you said this, but if I understand it right, I really want to drive it home. So for rib x-ray, I've always thought about it being different positioning of the patient, but it's not just that. It's also that electron beam is different.
Yes. Yeah. So so we take the x-rays differently, just the actual electron beam. It's the strength of the beam that we use. That part of it's different, but we also patient the position differently. So you'll notice that on rib x-ray series, we get these additional oblique views, which really help lay the rib out and increase our chances of seeing mildly or sometimes even minimally displaced fractures. So, and I'll show you a few examples of those. All right, so this person has rib fractures. Where are they? I don't know. All right, so we're gonna zoom in. So now here's our oblique view, okay? Now we can see where those rib fractures are very nicely. There they are. They correspond with that radio-opaque BB that we put on these patients if they can actually point to where their pain is. And I'll give you this zoomed up version here. Again, those arrows are pointing out where these mildly displaced fractures are. In hindsight, could I go back and say, yes, I see these rib fractures on the frontal chest view? Maybe, like 50% of the time. But prospectively, it's very difficult for us to find these. Another example, frontal view. This patient has rib fractures. Where are they? I don't know. I can't actually see them on this one. But thankfully, this was ordered with a rib series. So again, we get these oblique views, and here we see the rib fractures nicely. They're circled here, and here's a blown up image. You can see that we do have some mildly displaced rib fractures. So this is why ordering a dedicated rib series is critical if you are truly concerned about a rib fracture. All right, moving on. I beat that horse. Okay, so other chest x-ray limitations, if you're looking for a very tiny pneumothorax, it's difficult for us to pick it up. Some people will give the caveat in the report, there's no visible pneumothorax. In my mind, if it were visible, I would say something about it. That's my job. So just keep in mind, if we say no pneumothorax, it does not exclude a very, very tiny apical pneumothorax, for example. Additionally, without a lateral view, our ability to assess for smaller trace pleural effusions is limited a little bit. Even with a lateral view, we can't pick up an effusion that's smaller than like 75 milliliters. So just keeping that in mind as well. Other limitations with chest x-rays are just patient-dependent factors, which we do our best to work around. Patient positioning, motion, if they're breathing, we do get motion artifact on x-rays. Body habitus. More advanced radiologists who have seen more are used to interpreting images with patients do have a larger body habitus, but just keep in mind sometimes it can be a limiting factor. All right, So moving on to the third and final question that is going to take up the most of this time. What do you see on an X-ray? What do all these white and dark blobs actually mean? Well, we're going to break this down based off of what our search pattern is. So we're going to first address, when you're looking at the lungs, what are some things you could see? How do you know what they are, what to call them? Then we're going to move on to the pleura, which is fairly short and sweet, thankfully. And then we'll move on to the cardiomediastinal silhouette last if we do have some time. So first off, yes. I think he's going to bring the mic to you. Yeah.
This probably reflects my ignorance, but is it like you order a 2-view chest X-ray? Does the protocol get it all adjusted for the patient? For example, for like body habitus?
Yes.
It does. So,
yes.
So like exposure time, et cetera, gets adjusted.
Yes. So most of our X-ray machines now, if not all of them, the exception would be if the hospital happens to have some incredibly old X-ray machines lying around, but most of these machines have automatic exposure controls. So they automatically detect how much tissue is in front of them and will adjust as much as they can for it. But as I'm sure you guys have seen in your clinical practice, there are some times when we can only adjust so much. So, but yes, yeah. So that was a good question though. All right. Okay, so we're going to start off with our first pick here, lung parenchyma. But first we're going to pause. I just want to set everything straight first. We're going to do a quick terminology refresh, just in case I haven't drilled it into your guys' minds yet. If you see anything white or bright, any stuff that looks white or bright on an X-ray, you're going to call it an opacity. Parenchymal opacities, now we're talking about the lung parenchyma here. So they can be an airspace opacity, which is an alveolar process, or it can be an interstitial opacity. Now here's the fun part. All consolidations are opacities, but not all opacities are consolidations. I will explain a little bit, but I just want to kind of sow the seeds right now. And again, we do not use the word infiltrate anymore, okay? If it slips in, that's okay, but just be aware that that's just not the terminology that we use anymore. All right, so now we can resume back where we were at. So the first thing we're going to talk about is atelectasis. Atelectasis does appear as an opacity, white stuff on a chest X-ray, but what that stuff is volume loss, so alveolar collapse. You can see a range on X-ray, and you're going to see a range of terms that we might use that all describe varying degrees of volume loss. You can see minimal bibasilar atelectasis, meaning there's some like schmutz, some white, bright schmutz in the lung bases. That's just atelectasis, because honestly, we all have it. Unless you're like super, super healthy or have really bad emphysema and there's no lung parenchyma to collapse, you have a little bit of atelectasis. That can become subsegmental. It can become segmental atelectasis, or you can even graduate to where your entire lobe is collapsed. Lobar collapse just means your entire lobe is atelectatic. It's lost its volume. So direct signs that we see on chest X-ray, we're going to see linear opacities. Typically, this is in a dependent location, hence bibasilar is always the term thrown around, or posterior dependent if you're reading a CT report. Indirect signs that we're going to really kind of drive home over the next couple of minutes. We're looking for hemidiaphragm elevation because, again, remember, this is a process of volume loss. So as lung parenchyma is kind of shrinking, it's pulling other stuff with it that it's attached to. So diaphragm is going to go up. Fissures, such as the minor and major fissures, are going to get pulled towards wherever that atelectasis is. So if it's in a lowered lobe, that fissure is going to get pulled down, and you can see this on X-rays. The mediastinum, in cases of lobar collapse, is going to get pulled towards the opacity. Another clue for atelectasis is, especially if you're reviewing X-rays of one of your patients and they just came out of the hospital, it can be a waxing and waning process as well. So that's another clue that you're looking at atelectasis, and not something like aspiration or pneumonia. So a few examples here. Over the next few slides, the current study that we're looking at is going to be on your left. And then I also included a prior same patient, just to give you a reference point that's going to be on the right side of your image. So on this patient, they have mild left basilar atelectasis. And I know that because the left hemidiaphragm is pulled up just a touch from where it was on the prior study, which again is on the right side of your screen. So here's that diaphragm that's elevated just a touch compared to where it was on the prior. And if you're not sure, compare it to the other side. We love comparing sides in radiology. It's like our cheat code. All right, this one is a little bit more obvious. This person has right lower lobe atelectasis. So you can see on the current study, this linear band of opacities, white stuff, a white line in the lower right lung. And if you look at the prior study, it's actually higher. It's more kind of mid-lung zone. Here's our arrow here. So this is right lower lobe atelectasis. That's why the opacity, hopefully you guys can see my arrow here. So that's why this opacity that's formed compared to the prior study, that's not pneumonia, it's not aspiration, it's atelectasis. And we know that because this fissure has been inferiorly displaced. It's being pulled towards that area of volume loss. All right, one more example here. So this is an example of lobar collapse. Now I will say upper lobar collapse is a little bit trickier to identify than lower lobar collapse. Our left image here is an example of right upper lobe collapse. Sorry, I switched that around on you guys. I'm used to my sides being different. So here's our right upper lobe collapse. Here's actually that fissure. It's been pulled all the way up and towards the apex. Your right-sided image is the left upper lobe collapse. So this thin white line here, I'll give you guys some arrows, but on the right-sided image where it's left upper lobe collapse, that thin white line, that is the left fissure. It has been pulled all the way up into the apex because the left upper lobe is collapsed. All right, another example of lobar collapse. In this case, we have right middle and right lower lobe collapse. And this is kind of where our concept of silhouetting, the blobs that we're moving, cool animation slide. It's where this concept comes into play. So on the left side, we have right middle lobe collapse. If you can recall back to your anatomy, if you're thinking or remembering of a cross-sectional view of the chest at the level of the heart, the right middle lobe is actually the right-sided lobe that abuts the heart border. The right lower lobe does not. So when we have obscuration or we lose our ability to see the right heart border, that tells us it's a right middle lobe process. Hence, on your left-sided image, we lose that right heart border, can't see it anymore. It's a right middle lobe collapse. Now on the right image, different patient, but we still see our right heart border here. But we still have inferior displacement of that right fissure, and we have all this opacity in the right lower lung. This is right lower lobe collapse, okay? Here are arrows. All right, so that's volume loss, atelectasis. We're gonna move on to consolidation now. Consolidation is still an opacity. It's a white blob on your chest x-ray, but this is a space occupying process. It is not volume loss, it is taking up space. You have macrophages and all the stuff that I have forgotten long ago because I do not practice that anymore in the alveoli themselves, okay? So consolidation, in contrary to what you will see on reports, even from some of my residents here, consolidation is not the same as atelectasis. And that's because typically when we use the term consolidation, we're implying that it's an infectious process, it's pneumonia, okay? So just a quick step back, consolidation as opposed to just some other opacity, it's a very dense opacity. It obscures the underlying vasculature. Sometimes you can still see air bronchograms, sometimes not. Depends on if there is gunk in the airways themselves. So, but kind of skipping forward again. So consolidation, when we use that term, we're often saying that it's some sort of pneumonia. Now, technically speaking, not all pneumonias are infectious, but for your guys' sake and what you typically see, we're just gonna go with infectious pneumonia for now. Now you can have the classic lobar pneumonia, typically associated with bacterial etiologies. You'll also see us say a lot in our reports, could be an atypical infectious pneumonia, an atypical pneumonia. What does that even mean? Only a few people know. It's this like rare treasure. When we say atypical pneumonia, we just mean that it doesn't have that classic appearance. Typically, that means that chances are it could also be, or alternatively be secondary to a non-bacterial pathogen, viral, fungal, to like non-tuberculosis, mycobacterial infection, things like that. That's what we mean when we say atypical infection. Again, with the consolidation, granted, it doesn't really impact clinical care much, but we can use the concept of silhouetting as well as lateral views to help us discern where these consolidations are. And that can help, in the future as well, because as you guys have seen, we recommend that you follow these consolidations up to make sure that they resolve and there's no underlying mass malignancy process. So consolidations, what do we see here? And this is also a great way to see where the normal location of fissures is. Okay, so we have a right upper lobe opacity here. We can see it on our frontal view, which is the left side image. Notice how the fissure is where we expect it. It has not been pulled all the way up into the apex. It's kind of sitting in the mid-lung zone. That's where we expect to see our fissure. Hence, I know this is not atelectasis. This is a space-occupying process. It's pneumonia. You can actually also see the fissure very nicely, as well as that upper lobe consolidation on the lateral view. So here are these arrows. That's just outlining where that fissure is. All right, another example here. Here we have a right lower lobe pneumonia. So we see this opacity in the right lower lung. It's kind of this hazier opacity, maybe not quite as obvious as the last one, but you can see here, you still see the hemidiaphragm nicely, but notice we also see the right heart border nicely. So that immediately is telling me that at least most of the process is in the right lower lobe. That is further confirmed by looking at our lateral view. And this is where the concept of the spine, the lateral spine sign comes in. So when we're looking at our lateral views and we're looking at our spine, what we want to see is this spine, it's going to be more opaque, so more white, brighter, higher up in the spine, kind of at the upper thoracic level. And that's because you've got tissue overlying it. You've got again, I'm not an MSK radiologist. You have your muscles, your soft tissue, your arm, it's overlying that region, so it's going to be darker. As you look down the spine, as you look towards the mid and the lower thoracic levels, it should become more lucent. It should become darker. You have less soft tissue overlying that area. If you see something that pops up and all of a sudden it is not as dark, you have a process going on. You need to raise question of it. So in this example here, okay, so this is where our arm is. It gets darker, 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 and then boop, it's super bright. There's a dense opacity here. And this corresponds kind of at the same level as this opacity on the frontal view. So this is confirming that this is a right lower lobe process. The lower lobe is posterior to the middle lobe. Okay, so that's the concept of the spine sign. It's very helpful. And here are arrows just pointing out everything we were just talking about. All right, now here's our do not miss. Tuberculosis. Don't miss this. This would be bad. For radiologists, we really can't miss this. That'd be bad. So just a reminder, tuberculosis, it's an upper lobe predominant process. Typically, we see consolidations, masses. Oftentimes, they cavitate. We can see the miliary pattern where it's a whole bunch of tiny micronodules. It's harder for us to pick up on X-ray, but we can pick it up. We can also pick up the lymphadenopathy that's typically associated with it. In this case, the current study is on the left. We have a study from 2 months prior on the right. So this was actually a case of reactivation TB. So you can see, and this is also kind of a plug for having prior images to compare to. If you know your patient has had prior imaging, please send it to us. It is very helpful. So in this case, 2 months prior, we saw these linear band-like opacities in this left upper lobe. And then fast forward to the current study, which again is on the left side of your screen. We have increased nodular airspace opacities throughout that left lung. There's this increased mass-like consolidation in the left suprahilar region. So all that's consistent with reactivated infection. All right, aspiration. So aspiration is the fun one. Reticulonodular airspace opacities. And what that super long word means is that you have a combination. It's basically you get gunk in your airways and it can outline, we can see the manifestations all the way to the level of the alveoli, or the clusters. So the reticulo part of that is the more kind of lace-like pattern. That's where the terminal bronchioles, those structures, that's what's being emphasized by that first part of the word. The nodular pattern is the little tiny nodules that branch off of those more linear areas, and that's just those clusters of alveoli. So I really love this image, as unfortunate as it was to the patient. They were doing an esophagram and had a massive aspiration. So we can see the airways beautifully. Stunning image. Super unfortunate event though. I'm just going to give you a zoomed up image here. So again, hopefully you can see my cursor here, but we have the reticulo part of this word, the linear portion here. And then at the end of each of these, you can see these little nodules. So that's the nodular portion. So this is the radiographic equivalent of what you will see us refer to as tree and bud nodules or opacities on CTs. So tree and bud is just the CT terminology for this reticulonodular appearance. But now when you see the findings on CT, you can kind of get a better understanding as to why they look the way they look. Yeah. Oh, that's so unfortunate.
Let's see if we can.
Can I annotate on here maybe? Huh.
Maybe the laser pointer there.
Yeah, let's try that.
You can see that now.
Yeah. All right. Sorry about that, everyone. Okay. So I'll take a quick step back. So these lines here, these opaque lines, that's the reticular part that I was referencing. And then all these little tiny nodules around the edge here, kind of these clusters, that's the nodular portion that I was referring for those of you online. Okay, so, and all this is just debris in the alveoli. Okay, so typically aspiration, what are we looking for? We are looking for a dependent location. Again, it's if someone's aspirating, it's going to go where gravity goes. One thing that I think is just kind of an important caveat to remember is someone can aspirate and it can resolve in a few days. It can lead to an infectious pneumonia depending on what they aspirate. If they, have been vomiting and they aspirate gastric contents, depending on what they just ate, they could get an infectious process. Alternatively, it can turn into just an inflammatory process. Gastric acid isn't not what the lungs want to see. They're going to get irritated. So in that case, it's just an aspiration pneumonitis. But all these things kind of go hand in hand together. Another just kind of word of caution is we oftentimes see aspiration with atelectasis. If you think about it, it's gunk in the airways. Well, gunk in the airways is going to be aspiration, but that can also lead to volume loss, collapse of those airways then. So just important to remember that these things go hand in hand. So if you see kind of some hedging on our x-ray reads where we're saying, oh, it could be this, it could be that, it's not because we're trying to be difficult, it's just because there can be some overlap. All right, so these are a few examples of aspiration. So this is a case of right lower lobe aspiration. I'm going to zoom in here for you of that right lower lobe region. And you can see just some of these, again, lines in here. And then there are a few tiny little nodules that you can make out, just some more nodular opacities. It's not nearly as pretty as the unfortunate case of the aspirated barium, but it kind of follows the same general picture. All right, so moving past that, we're going to talk about pulmonary edema. This one can be a little tricky sometimes. There is variation even among radiologists as to kind of whether or not we call edema, to what degree we call it. Oftentimes kind of amongst radiologists, we refer to ourselves as either wet or dry readers. Wet being we are more likely to call edema, dry being we are less likely to call it. I will admit I am probably the driest reader in our chest section here. It's just how I was trained. But despite that, this is the general approach of most radiologists, okay? So first off, the radiographic presentation of edema does somewhat depend on what that underlying etiology is, specifically if it's cardiogenic or non-cardiogenic edema. It kind of influences a little bit as to the natural progression of edema and what signs you can actually rely on. So for cardiogenic edema, first, typically we see this vascular redistribution, which is we also term as cephalization. And what that just means is the blood flow is being directed into the upper lobes. So we see that upper lobe pulmonary vasculature stand out more prominently, becomes a little bit wider, becomes more opaque or wider or brighter, whatever term you want to use. We can see it more easily. That then progresses to interstitial opacities. So interstitial opacities are, it's more of that reticular appearance. It's where the bronchovascular bundles are traversing within. So it kind of takes on a more like hexagonal shape on CT. I should have included an image here. But we also see peribronchovascular opacities, and I will show you guys an example of that. But basically, the interstitial edema is going to follow the course of the lymphatic system within the lung itself. The lymphatic system within the lung travels in two different areas. One is around your more central airways, those bronchovascular bundles, hence the peribronchiolar opacities that we see. It's those lymphatics that kind of get engorged and start seeping fluid a bit. So the appearance on X-ray is this fluffy, hazy indistinctness around the airways are the most easy things to see because it's the contrast of the dark airway with the brighter, the wider edema. The second place that the lymphatics travel in the lungs is within the interstitium. And the interstitium is kind of this layer of tissue or fascia that kind of encapsulates these larger, multiple clusters of alveoli, essentially. So you're not going to get that nodular, fluffy airspace opacity. Instead, you're going to get these lines on your X-ray. When that becomes pretty fluid, then you get what you guys are probably all familiar with, these curly B lines, okay? Curly B lines are these horizontal lines in the periphery of your chest X-ray, the key being that they touch the pleura, okay? They touch the pleura. If they do not touch the pleura, they are not curly B lines, they are something else, probably atelectasis. And then after that, then you can start seeing kind of these more confluent airspace opacities that kind of often describe that bat wing appearance, the perihilar opacities. On the flip side of that is non-cardiogenic edema. Oftentimes with non-cardiogenic edema, we don't see that vascular redistribution. We cannot rely on that. The lack of awareness of this particular kind of caveat is what leads to radiologists, in particular, overcalling edema. And the reason why I'm telling you guys this is because I don't want you to be confused by varying chest X-ray reports. That's really the key piece from this. You might see one radiologist calling edema, and the next one just a few hours later saying there's no edema. If you have a question, just call the radiologist, and we'll be more than happy to answer it for you. But that's not a you problem, that's an us problem. So, and then also for non-cardiogenic edema, depending on the etiology, some radiologists, like myself included, we group it into acute lung injury because it's just part of that process as opposed to a process that would require like diuresing, for example. So lots of words, let's show pictures now. So this is an example of cardiogenic pulmonary edema. What we can see here is, so same patient, we have frontal and lateral views, but here we see cephalization of those upper lobe central pulmonary vessels here. So we can see those vessels really nicely here. They're much thicker or wider than what they typically are. What we also see are these interstitial opacities. Let me see is that working? Nope. So we also see these faint lines in here. So these are these interstitial opacities. You can also appreciate a little bit on the lateral view as well, these faint lines that are extending from the hilum out. And we also see peribronchovascular cuffing here. So if you look at the more central airways, you'll see that there's this surrounding rim of fluffy whiteness. Usually that rim should be very nice and thin. I tell my residents, you should be able to trace it with a sharpened pencil tip, okay? If you can't, if it's too fuzzy, if you should be like using a dull pencil tip instead, then it's too thick, okay? I will say there is a caveat that I've noticed being out here in Colorado. I don't know if it's the altitude or whatnot, but because I come from the Midwest, as Steve mentioned, everyone's bronchi here, or the walls are slightly thickened. It's like a thing here. I don't know why. I haven't been able to find any literature on it either. Also, everyone's pulmonary arteries are slightly larger than at sea level. Again, I suspect it has to do with the altitude. I have not been able to find any literature on it, but it has been a very constant observation for the last year and a half. So just keeping that in mind. Another thing with this, going back to the case, notice how large the heart is. So again, that just reinforces that this is a cardiogenic pulmonary edema. All right. And then this is another case. The initial study with the edema is on the left again. So you can see all of these linear opacities kind of extending from the hyla out. You can see that some of them even touch the pleural surface. Those are your curly V lines. And then just as a comparison to normal, the same patient a week and a half later, once that edema has resolved, is showed on the right, okay? Just notice that you can still see vasculature in the lung parenchyma. It's just not as florid as when someone has edema. So this is kind of a more advanced concept when you're starting to kind of decipher between mild edema and normal. Again, just give your friendly radiologist a call and we can help you out. All right, so quickly, a bonus slide here on emphysema, because I'm sure you guys see a lot of that. Just a reminder that with emphysema, we are looking for hyperexpanded lungs, which can be displayed by noting this anteroposterior widening on the lateral view. We get this widened retrosternal clear space. So here's your sternum. You should have this clear space behind it, but it becomes larger in patients with emphysema. We also have flattening of the diaphragms because there's so much extra volume now. And then in patients who have bullous disease or very severe advanced emphysema, we'll get these biapical lucencies. That's just where the bullous changes are. One note to make is that most patients with emphysema do have a normal chest x-ray. Okay, it's just patients with severe advanced emphysema that we can start seeing these changes. All right, so then quickly here in the last few minutes, we're just going to go over the last two parts of our search pattern here. So when we're looking at the pleura, when we're looking for pleural effusion, on imaging appearance, we're looking for kind of a meniscus appearance that's resulting in blunting of that costophrenic angle. When the patient is supine, sometimes it will instead see a gradient of haziness. And the way I explain this to my residents is if you were to take like a water bottle with like Kool-Aid or something in it, or even a coffee cup, and just imagine as you're tipping it back, that water line is going to start shifting, okay? It's going to become dependent. So you're going to get this gradual haziness that's going to be more opaque or darker dependently and gradually become lighter and then just kind of disappear without a distinct line as you look more towards the mid and the upper lungs. But again, that's on a supine image. Just a few caveats of chest radiography when it comes to effusion. On a frontal upright chest x-ray, we need at least 175 mLs of fluid to be able to see it. On a lateral chest x-ray, that number goes down to only 75 mLs. So lateral chest x-rays do help us be a little bit more sensitive for very tiny trace effusions. All right, so here's an example of an effusion. Same patient, frontal and lateral views. The right effusion, you can see a little bit of a meniscus sign there. And then on the lateral view, so this is the right hemidiaphragm here, you can see that there is some blunting and again, another kind of meniscus sign appearance of that posterior right costophrenic angle. The left effusion is larger. I would call this a moderate volume effusion. Again, we see that meniscus really nicely here, that upward turning of the opacity. And then on the lateral view, again, we see that meniscus sign. Notice how the left costophrenic angle is completely obliterated on both the frontal and the lateral views. All right, so pneumothorax. As we all know, pneumothorax is when air enters into the pleural space. It's separating the visceral and the parietal pleura. This means that we can see the visceral pleura as a thin white line on chest x-ray. White line. It's white because it's tissue. It's tiny tissue, very thin, but we can see it, and it is white. It's an opacity. So, some tips. If you suspect a pneumothorax and say we haven't gotten around to reading your image yet, you will not see any parenchymal markings beyond that line. That line will not cross the mediastinum or extend outside the thorax because it's pleura, and pleura doesn't do that. It's not going to go somewhere it doesn't belong. The other final tip, caveat, is beware of the skin fold. This is what most commonly gets confused for pneumothorax. So this is not a pneumothorax. On the right here, we have these linear, dark lines right here. Here are arrows. These are skin folds. This is not a pneumothorax. This is a pneumothorax on the right here. This is a zoomed up image on the right. So here we see parenchymal markings. No parenchymal markings outside of it. thin white line. This is a pneumothorax. This is not a pneumothorax. On the left here, we have these dark lines. This is a skin fold. This is a pneumothorax. Still on the left. Again, parenchymal markings where the lung is. No parenchymal markings outside of it. Nice, thin, white line. Now, this one is trickier to see, I will admit, but there is still a thin, white line. This is a pneumothorax. One quick thing that I think you guys rarely see, but just in case you do come across it, is tension physiology. You do not want to miss this. Essentially, very large effusions, large pneumothoraces can exert mass effect on the heart. That can result in cardiopulmonary arrest, hemodynamic compromise. We can see imaging signs that raise concern or question of tension physiology, in which case we tell providers to go get an echo to confirm. Those signs include contralateral mediastinal shift. So it's because this is a space-occupying process now. There's too much fluid, too much air, so it's pushing the mediastinum away from itself. Contrast that to when the lung is collapsed and there's volume loss. It's pulling that mediastinum in towards it. Other things that we can see for tension is flattening or depression of the ipsilateral hemidiaphragm. So the same side that that process is on, we'll see that diaphragm pushed down. And then we can also sometimes just see a collapsed lung. So this is a patient with a spontaneous pneumothorax. Notice how most of this lung is collapsed. We have flattening and even some inversion of the left hemidiaphragm. The mediastinum is pushed slightly towards the right. So in this case, I would tell the provider, go get an echo, make sure this person is okay. They would get a chest tube regardless, just based off of the size of the pneumothorax, but the urgency behind it is kind of where the importance comes in. All right, and here is the wonderful golden arrow. All right, so last up, do we have time for a few more slides? 2 more minutes, I can do it. All right, cardiac size. So on a PA view, which is the one that you guys are going to see, we're going to use something called the cardiothoracic index to help you decide if your heart, the heart you're looking at, is normal size. Basically, you're going to take the maximum horizontal length of the heart and divide that by the maximum horizontal length of the chest cavity. That's from pleura to pleura or ribcage to ribcage, whatever you want to remember. Anything normal is less than 0.5. 0.55 is like borderline. If it's more than that, on a PA view, when you don't have the issue of magnification, then you can use this. On AP views, so typically portable views, single frontal views, you cannot rely on this at all. Instead, you need to rely on other imaging findings that could suggest specific cardiac chamber enlargement, comparison to prior imaging such as cross-sectional imaging. All right, and this is just a reminder of that magnification process. So in this patient, this patient had new cardiomegaly. From a year ago, his heart was normal size, and now we have his heart's massive, unfortunately, on this. What this ended up being from, and this is why it's important for you guys at least to be aware, he had a new very large pericardial effusion, and you can actually see it on the lateral really nicely. Again, a little bit more advanced, but this kind of wider region here is the heart. And you'll notice that there's this kind of light, like slightly darker stuff around it. That's actually the fluid. So yellow is the fluid, the red line is the border of the heart, and I'll kind of toggle back and forth just to help you see. We don't see this all the time, but this is just too good of a case not to show. So large pericardial effusion. Other things, if you do see a newly enlarged heart, you have to be concerned about heart failure. So, but again, something that you guys will probably not come across much. Mediastinum. Just important things on your lateral view. I mentioned that retrosternal clear space. If you lose that clear space, you need to do further follow-up. In this case, there's this opacity that is now taking up what should be this nice clear space between the sternum and the heart. This person actually has a thymic carcinoma. So there's a large anterior mediastinal mass there. There's one other concept called the hilum overlay sign. It's basically applying the concept of silhouetting to the hilum itself. And let's go, so there's your arrow. All right, so quick refresh on what silhouetting is. Remember, we're looking to see whether or not there's that dark line separating it from the adjacent structure. In this case, this left lung mass, we do see that curvilinear lucency, so we know that this is a parenchymal process. It is not a mediastinal process. So this is the hilum overlay sign in action, and this is just kind of my last few slides here. So in this case, we have this left mass, but notice how when we zoom in, we can see the vessels through it. Here are your vessels, right there. So this tells us where the vessels are, which is the hilum, or the middle mediastinum. Since we can see the vessels through it, that tells us that the mass is not directly touching it, which tells us that this is not a middle mediastinal or a hilar mass. This has to be anterior mediastinal or posterior mediastinal. And in this case, this is some metastatic malignancy, but this was an anterior mediastinal and pericardial process. So the hilum was spared in this case. This is kind of on the flip side of that now. Again, we still have a left-sided hilar mass, but notice now here in that central area, we do not see any vessels. There's nothing there except surgical clips. That's what those little linear opacities are. So in this case, it tells us that this is a hilar process. It is involving the hilum. It is involving the middle mediastinum. And you can see here how this mass is kind of just completely involving that left hilum there. So, quick summation of everything. We've answered our 3 questions, the how, when, and the what. Just a reminder, standardized approach to chest x-rays. To order a chest x-ray, just don't order it for rib fracture, please. It's like, if there's one thing you take away from this, remember silhouetting, and don't order a chest x-ray for rib fractures. And then the what do you see, just remembering that concept of volume loss versus a space-occupying process. And to just give us a call if you ever have a question. We're here to help. Thank you. That's all.
Thank you, Dr. Robb. If you have questions, please raise your hand or type them in the chat, and I'll start out. Speaking of how to order chest x-rays, question I always have. So when we go to actually order it, we get prompted with different questions. For example, what symptoms is the patient having? What questions do you want answered? Scheduling, other. First, two-part question here. So first of all, what information from that actually gets through to you? And secondly, how much or how little is helpful for you?
Yeah, so all the information as far as symptoms, reason for exam, specific questions, that does come across to us. But the way our Epic profile is set up is it's really what you free type in as the reason for exam. That pops up like centerfold for us. That's what we look at first. And then I think there might be some like check boxes for you guys to select from as far as the indication goes. We do see that as well. But we tend to find that the actual reason you guys type in is usually more accurate and more helpful instead of just whatever click box might have popped up first. Yeah.
How much information?
Right. How much information? Kind of just what is your clinical question? If this patient has a unique history that's making you ask that question, that's helpful, but we have access to what their medical history is, surgical history, things like that. So just what is specifically pertinent to that specific question. Yeah.
Chat, could you review the process for having outside images reviewed, compared? Is that something that's done? For example, one of the questions that we get prompted with are if there are there any prior films available? And so if those films are available, but they're only outside, what's the process there?
That's a great question. And I've never had to do it, so I don't actually know. So I'm not sure if you guys have a specific order for uploading to like PowerShare, but we can typically upload images from there, cross it over to our packs. As far as actually consults, we're not going to do any consults on chest x-rays, I can say. But as far as the actual upload process, it was a great question that I have never actually had to answer because, like I said, I don't really do that. But I can find the information, email it to you, and then you can disseminate it if that would be helpful.
That would be helpful. I have not experienced that myself. I'd love to know the answer. If there's anyone attending on Zoom that does know the answer, please put that in the chat. Another question we have is tree and bud can be seen with processes this is a question. Can tree and bud be seen with processes beyond aspiration? And if so, is differentiating those processes based on history, or are there imaging differences?
Yeah, so yes. So tree and bud nodules, this is kind of applies to X-rays and CT. So whether it's reticular nodular or tree and bud opacities or nodules, essentially that is a marker of bronchiolar inflammation. So you can see in cases of things like bronchiolitis, and essentially aspiration is a form of inflammatory bronchiolitis. We just know it or suspect what the specific underlying etiology is. So the first part of that question is no, that term is not specific to aspiration, can be used in reference to other just general inflammatory findings. The answer to the second part of that question is it does strongly rely on what the provided clinical history is. So if you guys suspect that it's aspiration, if I look at the patient demographics and I see this is an 80-year-old, I'm immediately thinking aspiration because older people tend to aspirate. I'm sure I've even aspirated several times at this point in my life now. So yes, clinical history, patient demographics. If it's a young person, say they're 30, 35, coming in and I see those tree and bud opacities and they haven't been, found down or undergone like a cardiac arrest or something. If this is purely an outpatient setting, then I'm going to be very not inclined to call aspiration and really pursue further workup to get to the heart of what is causing this bronchial inflammatory process. Does that help answer the question, hopefully?
I think it does. Thank you.
Let me know if I can further clarify.
And then for final question for today, I'll take it. So I've noticed, maybe it's been there forever and I was oblivious, maybe this is fairly new, but for chest x-ray reads, there's a clear read.
Right.
And I don't know what that is. Excuse me, not the reads, but on the images. There's some sort of computer-generated clear read.
Yes.
I don't know what that is. Is that something that is helpful that we should be looking at? Is that something that we don't need to worry about at all?
Don't worry about it. No, I don't even use it as a radiologist. So what it does is it's an AI-generated image, essentially subtracting the bones. So the thought behind it is that it makes it easier to identify parenchymal processes. So one of the caveats of looking at x-rays is the ends of ribs overlie the chest where the lungs are. And sometimes those can be mistaken for masses or nodules. Sometimes it's hard to say. So the thought behind this AI generated image is remove the bones and you remove that caveat. I personally do not like relying on those because it's not a perfect technology, and sometimes it subtracts out opacities that it should not be subtracting out, essentially. So sometimes it can be helpful. I personally do not use it, and I don't know of many chest radiologists who do. So feel free to ignore it.
Thank you so much for coming today, sharing your knowledge, teaching us. Everyone, thank you for joining us for Grand Rounds today, asking your questions. Next week will be quarterly business meeting. That will not be located in AO1. That will be in RC1 in Hensel Phelps, the other auditorium that we have Grand Rounds in. Thanks, everyone. Have a great day.
Thank you.